With this week's Cardiology Countdown, we'll start at the number 3 spot with the publication of the ASCEND-HF trial. This was the large outcomes trial looking at nesiratide, the recombinant BNP that's a vasodilator and been seen to be useful in reducing pulmonary capillary wedge pressure. But big questions arose when pooling small trials raised the question of increased mortality. And so this large trial randomized 7,000 plus patients to nesiratide or placebo with acute heart failure. And they observed no increase in mortality nor worsening renal function that had been seen in the small pooled analysis. But they also didn't see a significant improvement in dyspnea. It was very slight difference of reporting of early dyspnea resolution, but not a statistically significant one. And thus this study refuted some of the concerns about adverse effects of this drug, but on the other hand really called into question its efficacy. And I think then ends likely a chapter of use of this. There may be selected patients where it's thought of, but it's certainly not going to be a new advance in management of acute decompensated heart failure. At the number 2 spot is an analysis published in JAMA from the NCDR Cath PCI registry that looks at the all-important appropriateness of PCI. This was an analysis of 500,000 PCIs performed from mid-2009 through September 2010, so very current data, and found that splitting the patients into the acute and non-acute indications, interestingly, 71% of all PCIs performed at the more than 1,000 hospitals in the registry were done for acute indications, and that would be for STEMI, non-STEMI, or unstable angina. And then the remainder were for elective non-acute patients. 98+% of the acute PCIs were deemed appropriate, and half of the remainder were uncertain from the database elements that were available. On the other hand, for the non-acute patients, 50% were seen as appropriate, 31% were uncertain, and that did leave 11.5% that were deemed inappropriate based on having low-risk, non-invasive testing and or being on submaximal anti-anginal therapies at the time of the procedure. Some limitations of a big database, but I think very reassuring that the vast majority of PCIs performed in the United States do look appropriate, with some room on the low end of patients that may not need cardiac cath on the basis of testing. So hopefully this can be useful in guiding appropriateness moving forward for PCI. And at this week's number 1 spot are the newly published ESC-EAS, the European Atherosclerosis Society's guidelines for dyslipidemia. It's a big document that reviews the entire literature and lays out what are appropriate tests to be done in evaluating dyslipidemia, where for risk assessment, they note that total cholesterol is used in the SCORE, the European risk thing, but also in Framingham, but that LDL really is the primary target, and triglycerides and HDL are useful markers of risk and should also be measured. Then in terms of treatment, they are pretty aggressive, and so they note that patients at very high risk, defined as established cardiovascular disease, type 2 diabetes or type 1 diabetes with organ damage, or CKD patients, or a SCORE level of risk of greater than 10%, should get as a class 1 level of evidence A recommendation a target LDL of less than 70 milligrams per deciliter. And so they've adopted really the most intensive lowering of LDL for a broad group of high-risk patients. Then they note for patients who are deemed high risk, and that would be markedly elevated single risk factor or a score between 5 and 10% for cardiovascular risk, and that's similar to Framingham, that a goal of less than 100 for LDL is listed as their Class 2A recommendation level of evidence A. And then for the moderate risk patients below that, a recommendation of less than 115. And so recognition in these guidelines that lowering LDL quite aggressively is now recommended and seen to be quite beneficial. So for this week's Cardiology Countdown, I'm Chris Cannon.